With the multidisciplinary tumor board meet. This will be moderated by Dr. Virendra. He's an assistant professor in the Department of Thoracic Surgery. And the panelists will be Dr. Nivedita from Radiology, Dr. Kunal Gala from Interventional Radiology, Dr. Naveen Mumadi from Department of Radiation Oncology, Dr. Rajiv Kaushal has joined us online, and Dr. Devyani from Surgical Oncology.
Thank you and good evening, everyone. So Dr. Kunal has come, so we'll start. Yes, esteemed panelists. So let's start our first case. It's so we don't have much time. We'll discuss two cases and try to cover as much as possible. This is a 73-year-old male with the ECOG performance status of 1, never smoker, hypertensive, diabetic, past history of pulmonary TB and extra pulmonary tuberculosis, also left femur 4 years back. Presented with cough since 4 months. Effort tolerance is 1 flight, limited because of this femur surgery, and he is walking with help of stick. So these are the images. I would like Dr. Nivedita to opine about the images with the available pictures. If you want me to go back, let me know. Yeah.
So I can see a speculated mass in the right upper lobe, along with the background of a lot of fibrotic changes. And I think there's a loculated effusion as well in on the right. And it is showing some kind of enhancement. Can you go to the next slide?
Yeah.
So definitely there's showing some kind of enhancement also, the lesion with associated pleural reaction. So it looks suspicious to me, the right upper lobe mass.
Okay, what is your opinion about rest of the parenchyma? How does it look?
So since the patient already has a history of tuberculosis, I believe the rest of the lung parenchyma shows the post-infective sequelae.
Okay. This is what we got the report also. I would like to ask Dr. Devyani. So Devyani, a radiologist has reported as a suspicious lesion. So do you need a biopsy, or you go ahead with that report and move ahead with for further workup, or do you need to confirm that thing with biopsy?
I would like to confirm with a biopsy in this case, especially since you said that old uses a walking stick, the lung parenchyma doesn't look great. So if it was something which was going to be a quick in, quick out surgery where you can send the budget out, send it for frozen, and then decide your further management, that's the only possible scenario in my mind where we can avoid a biopsy. But in something like this, where I'm questioning the decision of surgery in my mind in the first place, definitely biopsy.
Okay. And what is your opinion about the small loculated thing? Will you evaluate that also, or you'll ignore because there is a lot of other infective changes in the adjacent lung?
I agree with your point of view that with the amount of infective changes in the rest of the lung, the little bit of pleural effusion most likely might be reactive. But price to pay to just tap that effusion since you're anyway going in for a biopsy. But in the rare case that it comes positive, it's going to change our management completely. Yeah. So I think if you're anyway going in for an interventional procedure, this is
why not tap that and get a cytology? Okay, fine. So we did the biopsy, and this is what report we found. So I think Dr. Rajiv is also there with us. Sir, can you just briefly for the audience describe what important immunohistochemistry marker do you look into to characterize different type of NSCLC?
So when we when we get the biopsy tissue,
is he there on Zoom or no?
Yeah, so now I can't see the screen. That is the problem, but it's okay. So when we get the biopsy tissue, so first thing is we have to confirm the diagnosis of malignancy, if it is there or not. So if it is malignancy, then type of tumor, non-small cell versus small cell. And if it is a non-small cell, we have to categorize it to adeno versus squamous. That is the most common tumors. So if the morphology is very classical and there's showing nice glandular component or nice squamous areas with keratinization, there's no need for even ISC. You can save the tissue for molecular analysis. But if you're not very clear on the morphology and there are typical glandular or squamous features are not there, then in that case, we need to perform ISC, and minimum panel of ISC is done in the lung, that is TTF1 or napsin for adenocarcinoma, or P63 or P40 for squamous markers. So out of that, P40 and TTF1 are relatively preferred. They are more specific as compared to P63 and napsin. So these are the minimum. If you have to ask minimum markers, TTF1 and P40 are to be done.
Okay, sir, thank you. So I would like to take Dr. Kunal's opinion also, because this guy has a very bad parenchyma on scan. So when you are planning for a biopsy, are you more worried about, is there a higher complication in a patient with such lung changes, or it's the same compared to others?
Yeah, definitely there is more chances of pneumothorax, so need to counsel regarding the same thing. Might develop a pneumothorax, and drainage, the small bore drain could be required, needs to be counseled prior to doing biopsy.
Okay. So we need to be more precautious and be more vigilant about post-procedure complications.
Yeah, with small volume lung, so those are high risk for
biopsy. Okay. So I'll come to Dr. Naveen. He's a radiation oncologist in our center. Sir, now we have seen images. What staging workup will you ask for?
I would ask for a PET CT scan in this patient, and that will complete the metastatic workup. And in all patients who are being planned for any radical treatment, we would also get an MRI of the brain.
So is there any situation where you can avoid or MRI brain, or you'll go and ask for all patients?
So typically in patients who have peripheral small tumors, we generally can probably avoid not getting a PET CT scan. But in this patient, I would probably err on getting the PET CT scan then, because he has a lot of infective changes also. So give me an idea as to what exactly we are dealing with.
Okay. So we did PET as well as MRI in this case, and it was same what Nivedita pointed out earlier. It's a T1 peripheral lesion with no other disease anywhere. Even MRI brain is clean. So I'll come back to Devyani. You have seen images, PET is non-metastatic. You have seen patient also imaging findings. So what is your further plan? Where is the patient heading towards? Which kind of management do you think? Like, will you ask for any other functional evaluation to decide treatment, or you can take a call based upon the imaging finding?
Based on the way you described the patient's clinical status and looking at the lung fields, surgery looks a little bit unlikely and a little bit of a far-fetched treatment plan for this patient, but we wouldn't take this decision without a pulmonary function test in the first place, because I think the only other option would be sending the patient across to Naveen, and Naveen would require a pulmonary function test.
So yeah, Dr. Naveen, you will need PFTs, or you are fine? Suppose patient is planned for a non-surgical management. So will you need PFT, or how do you go ahead with that?
So although most of the times we are left with patients who are handed down by the surgeon, typically patients who are inoperable medically, we still would get a PFT-DLCO and read into it, basically because one, we have a baseline idea about the patient's lung function, and so that we can kind of predict what his functions may turn out to be post-radiation. Although we do claim that post-SBRT, the dip in pulmonary function is pretty minimal, but in patients who have a baseline very poor pulmonary function test, even that small dip might actually throw them completely overboard. So I would want to know baseline what we are dealing with, so that it also helps me to counsel the patient as to what side effects
So
is to
do you
expect.
keep
So,
any cutoff, like below this you will not give treatment
again,
SBRT?
yeah, so like how you guys have for surgical, how you predict a post-operative predicted values of FE1 DLCO and kind of have a threshold as to where you will and not operate. We do not have, again, for the same reason that we deal with hand-me-downs most of the time, but still we do SBRT in patients who have pretty poor PFT. But we don't look at the PFT DLCO values in isolation. We do look at what is exactly the pathology behind the poor pulmonary function test. Especially in patients who have interstitial lung disease, we are doubly cautious, because in those patients, SBRT can actually lead to worsening of their symptoms also, not just the PFT DLCOs. But if there is some other pathology, for example, this patient has a post TB sequelae, which might be the reason for his poor pulmonary function test, there I'm a little more confident that my treatment might not actually cause too much of issues.
So are you comfortable in giving SBRT to this guy, or you will look into PFTs and then decide?
I would still look at the PFTs for the reason that I said, that I would want to know what the baseline values are, and I'm okay doing RT for this.
Yeah, so we discussed in MDT and patient was planned for SBRT, underwent also, and is fine in follow-up. I would like to take Dr. Kunal's opinions. What is your opinion on treating peripheral T1 N0 NSCLC with the RFA or other RFA or microwave kind of in a medically unfit patient?
Yeah, so we have 3 modalities as of now. 2 are heat-based therapy, like RFA and microwave, and third is a cold-based, like a cryo ablation. So these are proven to be, if they then it is much more beneficial, because it does not affect the PFT at all. We take 1 centimeter margin as similar to the surgery, and the intent with 1 year, 2 year, and 3 year have shown to be beneficial.
Okay, so we have other modalities also, not only SBRT. So this patient underwent SBRT and fine on follow-up. Now next case is a locally advanced. It's a 63-year-old lady with good performance status. ECOG1, effort tolerance is also good. 3 flight, former smoker, hypertensive, presented with cough, dyspnea, and right-sided chest pain. On examination, it was fine. There was no supraclavicular adenopathy. So again, these are the imaging. I would like to, again, Dr. Nivedita's opinion. What do you see here? What is your view on the available pictures?
Yeah, so I can see a right upper lobe mass, which is actually infiltrating the chest wall, because I can see rib erosions. So it's a chest wall infiltrating suspicious right upper lobe mass. And in the given mediastinal window, I'm not seeing any node.
So in this picture, I think we are clear about chest wall involvement. Suppose you have a doubt about parietal pleura or chest wall. So do you have any other investigation which you ask for, or how do you go ahead with that? Or
I think chest CT scan is enough for commenting upon the pleural involvement and even the bone involvement, because here chest wall involvement, we would get an idea from the adjacent bone erosion and whether there's lysis and a soft tissue component associated. So the best imaging modality is a chest
CT chest. Okay, okay. So this patient also had a complaint of pain over the chest wall area. Most of the time we take control of that with medicines, oral medications. But suppose, Dr. Kunal, if it is not settling, can we offer anything to take care of pain by the time patient is undergoing preoperative evaluation or other workup?
RFA or ablation has been proven for pain palliation as well. So we can...
No, not the primary. Suppose we don't want to touch the primary. Okay. Primary may be tackled based upon staging workup later on. So can we do anything for pain without...
So now block with lignocaine and bupivacaine, and then later on to steroids so that the pain is relieved.
Okay, okay.
Recently, we started referring quite a few of these patients to you guys for the nerve blocks, and it's worked very well for us. So do you give a short acting before and see if it works?
Yeah, if it works, then we get it.
Okay, so you start with a lignobupi and then go on to steroids. And with steroids, how long is the pain relief? It's a neurologist.
Great, great. So we won't discuss about staging workup and function evaluation that we have already covered in the previous case. We did PET scan. It was right upper lobe lesion involving third and fourth rib with few medicinal adenopathy, and MRI brain was fine. Dr. Devani, do you need any kind of medicinal staging in this case, and what modality will you prefer?
Yes, definitely. It is a largish lesion towards peptal. And I don't think we saw any images in the PET showing up any very suspicious looking nodes. But even then, this is definitely a candidate for invasive mediastinal staging. So if we go by strict guidelines, it would be EBUS first and a negative EBUS confirmed with a mediastinoscopy. But time, cost, and logistics permitting would be both these. If I had to pick one, I would definitely at least go ahead with a mediastinoscopy, which is still the gold standard. Probably at the same time as the surgery, send the nodes for closing section analysis. If they're negative, go ahead with surgery under the same anesthesia.
So if you have both modalities available time also, then how will you
EBUS
followed by mediastinoscopy? Okay. So we did same in this guy also. We did pulmonary function test. PFTs were fine. 2D echo was also okay. EBUS was negative for any mediastinal node. So it was clinically T3, N0, and M0 disease. Dr. Naveen, what management option can you want to go ahead with in this patient?
So if this patient is functionally otherwise fine, going with a pulmonary function test, he is a candidate for surgery also. So surgery is the first option that I would also choose for this.
So again, coming back to a surgeon. So suppose this patient has a chest wall involvement. We saw PFTs, we calculated predicted post-operative values. So how do you account for the additional loss because of the chest wall resection? It's lung that we have calculated for, but how do you take that into consideration? Or
yes, definitely, because it's not just the lung parenchymal loss that the patient is going to have to deal with a part of the chest wall gone, and in this case, it is a significant amount of chest wall. We're looking at least at 2 to 3 ribs and a lateral defect. So it's going to interfere with the bucket handle motion of the patient's respiratory mechanics. So I don't think there's a fixed number to it, but somewhere between 10 to 15% is the value that if you have to put a value to it, that you would lose additionally. And the point that we need to be careful here is especially if it's a person with borderline lung function, plus a lung resection and a chest wall, we have to be aggressive with reconstructing the chest wall at the time of surgery.
Okay. So point well taken. So PFT loss, there is no clear-cut, mathematical formula as far as chest wall loss is concerned, but obviously we have to take that also in account. So this patient underwent surgery and with chest wall resection and upper lobectomy with SMLND. I would like to ask Dr. Raju, suppose a surgeon is a little bit, doubtful and he sends full specimen to you for a margin assessment on frozen. How comfortable are you in, commenting upon chest wall margin on frozen?
Yeah, so the margins which we, for any lung surgery, which we commonly sample, they are either parenchymal cut margins or bronchial cut or vascular cut margin. And if, as in this case, there is a chest wall involvement is concerned. So there can be two margins from the chest wall. It can be either soft tissue margin or the bony margin. So soft tissue margins we can sample in the frozen, but bony margins are difficult to process in frozen. So other alternative is if you really want them, the bony margins, we can make the marrow imprints and evaluate them. So that is the other alternative to, but bones sample we can't process in frozen. We can process the marrow, but not the bony margins.
Okay, so we rely on the soft tissue around bone and if needed, bone marrow imprint. Okay, sir. So this patient underwent surgery. HPR is T3N0, moderately differentiated squamous cell carcinoma with involvement of chest wall. I had a few questions about medical oncology, but I don't think we have Dr. Vijay in our panel. So, Dr. Naveen, what treatment would you like to, if you
Before I go into the adjuvant treatment, I think I kind of made your job easy by, when you asked me what management you would do, I said surgery and not CTIT. So probably just for the sake of discussion, I would take that and then talk about the adjuvant treatment. So T3N0 patient, although I said surgery, but if the surgical morbidity is significant, then CTIT is definitely an option. We have level 1 evidence to say that probably even in resectable patients, chemo-RT is a reasonable approach to. And given the fact that this patient has squamous cell histology and the rib erosion, and we do see that these patients do respond both radiologically and symptomatically well to RT, it's definitely an option.
Okay.
Having said that, now that this patient has undergone surgery with a more than 4 centimeter lesion, and can we just have a look at this?
Yeah.
Yeah. So all nodes negative, but the patient has T size of almost 7 centimeters. So this patient definitely warrants adjuvant chemotherapy. Sake of the audience, all patients with node positive disease receive adjuvant chemotherapy, platinum doublet for 4 cycles. And patients with any tumor more than 4 centimeters, even N0, also benefit with adjuvant chemotherapy, as large trials have shown this. Postoperative radiation has been always discussed in the setting of node positive disease, especially mediastinal nodal disease. However, in light of the recent publication of 2 major phase 3 trials which have evaluated postoperative RT in N2 state disease setting, has shown that probably we have kind of overestimated the effect of radiation in this patient. So standard treatment for this patient is adjuvant chemotherapy for that.
And what about chest wall? If chest wall involvement is there and suppose margin is negative, is there a role of RT or
as long as the margins are clear, we are okay, because this patient has a higher risk of systemic failure. But in patients who have positive margins, close margins, then definitely there is a indication of giving postoperative CT-RT.
So that is what happened here also, received 4 cycles of platinum-based chemotherapy and was on regular follow-up. I think we are done with our panel, 2 cases. Thank you very much. Thank you.